Hello, and welcome to this presentation by the Foundation for the Education and Research in Neurological Emergencies. This educational lecture is titled Managing Emergency Department Headache Patients, Life-Threatening Headaches and COVID-19 Implications. My name is Edward Sloan. I'm currently Medical Director of the Physician Assistant Studies Program at Dominican University, and I have been an attending physician in emergency medicine at Carle Foundation Hospital. I am Professor Emeritus in the Department of Emergency Medicine at the University of Illinois at Chicago. The content for this lecture comes in large part from the monograph titled Evaluation and Management of Life-Threatening Headaches in the Emergency Department by Dr. Zoda et al. It was published in Emergency Medicine Practice by EB Medicine, February 2019. Please refer to the complete video and audio content for this educational lecture, as well as other individual parts of this lecture via links found at FERNE.org. You may also refer to the initial podcast and the CME option on the EB Medicine website at ebmedicine.net and specifically at the link listed below. Please note the disclaimer listed below. In general, this information is intended to augment and not replace the clinical judgment that guides the management of any individual patient. Another important consideration, a secondary headache cause, is carbon monoxide poisoning. These patients will have headache, nausea, vomiting, and perhaps peripheral cyanosis. The common story is that 5 different people in the same building or house or apartment have headache. You should always assume that it could be related to some problem with the heating element and carbon monoxide poisoning. Patients can give visual changes, altered mental status, coma, and/or seizures. It can cause cardiac ischemia or cardiac arrest. Now, we note that venous CO levels can be 3 to 8% carboxyhemoglobin in smokers, and that lethal levels are in the range of 40 to 60%. Now, we used to say patients with carboxyhemoglobin levels greater than 25%, for example, would require transfer to a center that has a chamber that will allow hyperbaric oxygen therapy. And the question is, who needs to be transferred for hyperbaric oxygen therapy? Now, we know with a high level, it's probably worthwhile if you have HBOT in your own institution to go ahead and provide this hyperbaric oxygen therapy if it's going to be safe. But the question is, when do patients need to be transferred? Well, clearly patients who have a high level greater than the 24 or 25 range need to be transferred if there's signs of acute myocardial infarction, cardiac arrest or ischemia, coma and/or seizures related to significant CNS toxicity. Now, we know that the reason we do the hyperbaric oxygen therapy is to prevent some neuropsychiatric problem down the road, and it's difficult to predict how or when or why that might occur with or without hyperbaric oxygen therapy. But suffice it to say, patients with lower levels, perhaps less than 20% carboxyhemoglobin who have no symptoms except for headache, can probably be treated with high flow 100% O2 in the emergency department. And once their headache symptoms resolve, you could recheck a CO level as needed, but otherwise, knowing their first venous CO level might be sufficient. The one question that has come up is, what about pregnant patients? We know that the fetal hemoglobin has a greater affinity for carbon monoxide, and the question is, do pregnant females need to be transferred? I'm not aware of data that suggests any specific cutoff that needs to be addressed with regard to hyperbaric oxygen therapy in pregnant patients, except to say the higher the level of venous CO, carboxyhemoglobin, that is detected, the more you might consider the hyperbaric oxygen therapy in pregnant patients. When considering the diagnosis and treatment of emergency department headache patients, especially in the setting of this current COVID-19 pandemic, the following can be concluded. Emergency department headache patients who present with potential life threats can be identified. In order to do so, a systematic evaluation is critical, and the electronic medical record can help with this process. Most importantly, subarachnoid hemorrhage can be excluded in patients who present with sudden severe headache, given our current diagnostic capabilities. Also to be noted, head and neck infection, CNS infection, and CNS thrombosis must be considered if subarachnoid hemorrhage is excluded as the likely etiology for patients with potentially life-threatening headaches in the emergency department. During the time of this current COVID-19 pandemic, it is possible that common primary etiologies of headache, such as muscle tension headache, migraine, or even headache related to dehydration, can commonly be seen in emergency department patients. However, when considering patients with potentially life-threatening headache in the emergency department, at this time it is worthwhile to always consider COVID-19 as a potential etiology of these life-threatening headaches. During the time of this COVID-19 pandemic, besides specifically testing for the COVID-19 virus, there's no need to specifically alter our approach to diagnosing and treating patients in the emergency department with life-threatening headaches. If you have any specific questions related to this educational content, please send an email to fern.org@gmail.com. We encourage you also to go to the fern.org website for more content related to this educational program, as well as other content related to the care of patients who present to the emergency department with life-threatening illness and injury related to neurological emergencies. Thank you.